All right, we're gonna go ahead and get started with the ABSITE review. This is GI hormones and stomach. First one to you, Connor.
What is accurately describes gastric? Gastric is stimulated by adenosine. Gastric is inhibited by acetylcholine. Luminal acid inhibits the secretion of gastrin. Gastrin is produced by the parietal cells, where gastrin interacts with receptive chromatin-like cells to inhibit the secretion of histamine. She.
That's correct. So gastrin is one of your GI peptides produced by the G cells of the antrum. It's a main regulator of gastric acid secretion following food intake. It stimulates acid secretion via stimulation of the synthesis and release of histamine from enterochromatin-like cells, which then induce acid secretion by binding to the H2 receptors on the parietal cells. Unfortunately, this is just one of those things where you have to memorize all of the GI hormones, but the release of it is inhibited by adenosine, not stimulated by adenosine. It's stimulated by acetylcholine, not inhibited by acetylcholine. They're produced by G cells, and they promote secretion of histamine. That's why the other ones are wrong. Pat, you can still hear me, right?
Yeah, but I can't see the slides.
Oh yeah, you're right. I should probably advance them out here. So C was the right answer.
45-year-old man underwent an colic removal months ago. It's hard for me to see, so I can't see it.
I'd say it's more of a, it's supposed to be like an anticolic anastomose.
So in that case,
This one's actually Peterson's face. Sorry, I tried to get the picture as clear as possible. But here's just a picture of the different defects formed between the mesentery root limb. So Peterson's face is a defect between the mesentery and the root limb and the transverse mesocolon. The second one is the mesojejunal space, and the third occurs with retrocolic gastrojejunal anastomoses, and that's a transverse mesocolic space. So this one was trying to show you that it was Peterson's space. But overall, closure of mesenteric defects results in long-term, decreased long-term risk of internal hernia. They've done like randomized controlled trials. They decreased reoperation for small bowel obstruction within a 3-year period if you close the mesenteric defects. So that's the reasoning behind closing them. The majority of operations that we do are anticolic, but if you do a retrocolic, you're introducing another potential defect. Sorry, Pat. There you go. All right. Mag, are you able to answer this one?
Sure. Which statement regarding the classification and treatment of gastric ulcers is true? I think it's B.
That is correct. So gastric ulcers are classified according to their location, as well as the role in acid secretion. So Tommy Brown had a pretty good mnemonic for this one. So one, you just have one ulcer, it's on the lesser curve. Two, two ulcers on the lesser curve and in the duodenum. Three, try to remember it by being pre-pyloric. And then four, you would always say like near the front door, so high along the cardia or near the GE junction. And then five can be anywhere, and they're usually secondary to NSAID use. And the way he remembered that one is he said NSAID had 5 letters in it, which I think is a pretty good way of remembering. This is the Johnson classification system of gastric ulcers. The types 2 and types 3 are associated with increased acid secretion, whereas types 1 and 4 are decreased mucosal protection, and then 5, obviously, NSAID use. All right, Pat, you got this one?
49-year-old man comes to the office complaining of a 3-week history of abdominal pain. The pain is burning in character and improves after meals. He denies fever, vomiting, or bright red blood in his stool. On exam, he is tender to palpation in the epigastrum without peritoneal signs. On upper endoscopy, there's positive H. pylori tests, so he gets treatment for that. Which of the following is most appropriate to determine if the infection was eradicated? Breath tests, serology, endoscopy, and biopsy. And biopsy for culture 4 weeks after, or endoscopy and biopsy with histology immediately after completion. I think it's the urea breath test that we do, A.
And you are right. So medical ratification of H. pylori is imperfect. So usually current guidelines recommend performing either urea breath test, fecal antigen test, or a biopsy-based test 4 weeks after the end of medical therapy, but typically we go for non-invasive before we go for invasive testing. Another thing to just keep in mind are just knowing the triple therapy for H. pylori. So you can, everybody gets a PPI, but you can do amoxicillin and either clarithromycin or metronidazole, or sorry, you can do PPI, clarithromycin, and then either amoxicillin or metronidazole. If people have penicillin allergies, they'll get metronidazole instead. And then there's also the bismuth quadruple therapy, or you can do concomitant therapy where they get both metronidazole, amoxicillin, and clarithromycin. All right.
I don't mind going, but for ulcers too, one of the questions that came up for me this week was like, what's the most common cause of a bleeding gastric ulcer? And it was actually NSAIDs over like anything else, like smoking, H. pylori, and I forget what else was listed on there, but that kind of struck me as some, you know, I got it wrong.
Okay.
But for specifically for like a bleeding gastric ulcer, like NSAIDs is like the highest risk factor. It's a CSAP question.
Okay.
And then this next one, I don't remember. So what is the most common sarcoma of the GI tract? I would say gastrointestinal stromal tumor, interstitial cells.
Yes. So cysts are found in the stomach 60 to 70% of the time, remainder in the small intestine, rectum, and esophagus. We diagnose them based on immunohistochemical testing for the tyrosine kinase receptor KIT, which is CD117 and CD34. Treatment is based on tumor resection, and then if they have grossly negative margins, they don't typically get lymph node dissections. And then for locally advanced or metastatic, Gleevec is a tyrosine kinase receptor inhibitor, also called imatinib, that's used to treat them. It can be used neoadjuvantly or adjuvantly for people who are high risk of recurrence, adjuvantly.
It's three years, I believe.
For 3 years. Yeah.
50-year-old man presents surgical clinic, 3-month history of loss of appetite, 45 pound weight loss, nausea, vomiting, unremarkable, B-cell gastric lymphoma. All right. Antibiotic therapy mainstay program, multiple lymphoma, chemotherapy, radiation, surgical. So go with A for the multiple lymphomas.
Correct. So this one's A. Low-grade malt lymphoma presents as stage 1 or stage 2 disease. They have an indolent course. Basically, they've shown that if you eradicate H. pylori, you get 50 to 100% cases show complete remission. So they're treated with the triple therapy rather than with chemoradiation. Surgical resection is not essential for this, but it's just basically recognizing that this is a malt lymphoma and not anything else. So I keep getting these questions wrong.
If this was a large B-cell lymphoma isolated to the stomach, take it out to the answer is no. You do chemotherapy. They'll ask you that too. It won't be H. pylori related. H. pylori will be negative. It'll be like a large B-cell lymphoma, which can be isolated to the stomach and still chemotherapy.
You treat it essentially like any other lymphoma. You just do chemotherapy for it. And then surgical treatment. So kind of for E, surgical treatment is related to complications of radiation.
All right, we'll go back to you, Connor.
52-year-old woman is hospitalized with an acute upper GI bleed. Endoscopy exam reveals a 2.5 centimeter ulcer in the area of the insertia angularis. The other endoscopic findings are normal, continued bleeding, necessities therapy, optimal therapies, which are the following: tracheotomy, orthoplasty, overstone with bleeding ulcer, gastrotomy with overstone with bleeding ulcer, the proximal gastric ulcer, the distal obstruction area of A.
Actually, this one is D.
No, I said it's not A.
Oh, never mind. Sorry, I thought you said it's A. I do remember. Well, I'll give it to you. So best elective operation for benign gastric ulcers is a distal gastrectomy with a gastroduodenal anastomosis. Gastrojejunectomy is also an acceptable alternative. The ulcer should obviously be included in the antrectomy specimen. I feel like that one's pretty self-explanatory. This is just one of the score questions.
I think it's kind of crappy that they didn't give you like biopsy results or anything. Because like it sounds like we're on endoscopy. Next thing you know, we're like operating.
Right.
But I see like does their reasoning say anything about like the size of the ulcer, like why you would take it out? Like do they
Interesting, it's still bleeding.
Huh? Well, I was just kind of curious because like it doesn't even say we're in the operating room.
No, I
And,
know.
that's why I just wondered if they talked about that. Like I would have chose D, but just because then also you get a tissue diagnosis as well. Because none of these other ones include biopsy.
They don't mention reconstruction, which you have to do this.
No.
Yeah, I was just curious.
I thought it
in
was
the
like a
question
pretty
stem.
bad question, but
No, that's fine. I was just curious.
Is that why you don't do B then? So you can get tissue sample.
Yeah, I think at some point you'd have to, and so I just wondered if that was in the question set, like size of the ulcer. It's obviously bleeding.
So-
yeah, and then
the other
also
thing-
you're preventing recurrent ulceration by doing the antrectomy
By
with
taking
it.
out all the gastro-producing cells.
Well, this is essentially a type of radiation, so it's an acid secretion for one. So if you take out the acid,
I still think D's the best answer. I was just curious what their reasoning was.
I don't know. They just said antrectomy, which includes ulcer with gastroduodenoscopy, is considered the best procedure for surgical management of this complication. So,
Sorry.
and prevention of recurrent ulceration. It is your turn, Tom.
Okay. Which of the following statements is true regarding arterial blood supply to the stomach? Left gastro, flow arteries and brains with the celiac trauma cases of celiac, including gastric fibrosis, collaterally through short gastric, right gastric artery, branch of the SMA supplies gastric tissue.
She's seen this.
So it's not A or C.
Right. So stomach is extremely well vascularized. It's got 5 major arterial distributions. I put up a picture just because I feel like that's easier for you to see. The left gastroepiploic does not come off the celiac trunk. That's why that answer was wrong. Right gastroepiploic, while it comes off of the celiac trunk, doesn't come off the SMA. And then the short gastrics are not the only thing maintaining viability if you have celiac artery occlusion, because you have lots of collaterals. You have your GDA actually forms collaterals with your SMA between the celiac and the SMA. Then you get your pancreaticoduodenals that come up too. So you still have your gastroepiploics on that side, not just the short gastrics.
So if you're doing a Whipple and someone has celiac artery stenosis and you test clean the GDA, what would you expect? They have like high-grade celiac stenosis. So the GDA may be feeding their proper hepatic. So that's why we test clean the GDA. I mean, you should have pre-op imaging, but that's why we do that. So because it may be the SMA collaterals through the GDA may be filling the proper hepatic, and so you, by taking the GDA, you may like literally take their arterial supply to the liver, even though you're not taking the celiac. Just because it's not. That's another question. Yeah, exactly.
Another one they like to do if you're doing a gastric conduit after esophageal, what's the blood supply?
That's the question.
Yeah.
So you have to take down shorties to mobilize, and you're going to take down the parts velocity, right? So you're going to tubularize the stomach. Okay. So what blood supply?
So your stomach is going to essentially be like that.
It's the right gastric.
Right gastric.
Yeah.
The left gastroepiploic exists, but I don't think it's very like robust. Like when we take it, like when I've taken it intraoperatively, we're like, is that it? Probably, but you can't really tell. It's kind of just like where it stops. Like you'll see this like stop, and then it's like fundus, and that's usually where you start if you're doing like a toupee or a Nissen or something. That's kind of where you like start taking down your shorties.
So based on this, I mean, the other thing that comes into play is frequent, not frequently a question, but until it arises, because this condition is not normal. You have a young, healthy trauma patient who either has a stab wound or shear or something, and their celiac artery is injured. Their SMA is fine. What do you do with that? You're not going to feel great about it, but
I bring that up because I've had it happen. So. This was actually a deceleration. Exactly.
41-year-old woman has a history of building ulcer disease since the operation. Symptoms. Option is the bill on two, so this patient is having Afferent. So I think the fact is that if you started died on the short. So I would try.
They want you to go a shortening the afferent limb. But you're right, this is afferent loop syndrome. Occurs from positional obstruction of the afferent limb, results in accumulation of pancreatic and hepatobiliary secretions, causing severe epigastric pain, and then you get high intraluminal pressure that eventually resolves with.
Where is this question?
This is from Truler.
So I would do a Roux-en-Y or a whole one for on the sketch.
We can talk about this in a specific question, but I think the point is that like it's recognition afferent limb syndrome, and that like nowadays you should do like a really line. Right. And I think that would be on the test. It's probably just another question.
Yeah. So basically, like the recognition is that you have positional obstruction, then you get a high volume bilious vomiting and relief of symptoms, and that's afferent limb syndrome. And this is the depiction of the Billroth too. And so your afferent limb is proximal to your gastrojejunostomy, and that's what's getting either kinked, twisted, or just like filling with all the hepatobiliary secretions, and then after they have the bilious emesis, they resolve that obstruction and they feel better.
I don't know what they mean by short.
The syndromes usually occur when the afferent limb is greater than 30 to 40 centimeters in length, and has been anastomosed to the gastric remnant in an anticolic fashion.
I guess it's the same hypertendency or something, because the problem is if you don't make it long enough. Yeah, so it's problems too. So I think the key is just do a real one.
Stop doing the Billroth procedure. All right, Meg, are you still with us?
Let me just read the question and see if I know it first, and then I'll let you know if I'm still here.
Everyone can hear you.
With regard to operative management of gastric carcinoma, which of the following statements is correct? A.
Yep. You knew it.
Phew.
So gastric cancer, microscopic or macroscopic involvement of the resection margin is associated with poor prognosis. Extended lymphadenectomy, they're talking about a D1 versus D2 lymphadenectomy, has not been shown to improve survival in North American trials. It has been in Chinese, Japanese trials.
Yeah. Well, and that's D3. So like the Dutch trial is D2, it shows some benefit, but not
Survival benefit?
We're bad.
Clem, can you be louder, please? Because I can't hear you.
Japan has shown improvement in some of these. The American trials and like the Eastern trials have, or Western trials have largely not shown benefit because a lot of people did splenectomy and pancreatectomy on these patients, so they got pancreas leaks, and pancreas leaks are bad. So those patients did shitty. There's a Dutch trial. I think that was D2 though. Which periaortic nodes would be like a D3 resection. And so that is wrong for kind of a number of reasons, that answer choice. But in America, it's just never been shown to be beneficial. I guess the other thing is your nodal stations. So 1 through 6 is going to be your perigastrics. The odd numbers are on the left side and the even numbers are on the right side of the stomach. And so those we all take. And then your 7 through 11 are going to be kind of your D2. So 1 through 11 is going to be your D2. And then I believe it's 8 is that hepatic node. And so 8 or 9. I believe it's 8, don't quote me on this, is hepatic node. And so some people feel like that's the most important lymph node to take. And then 13 through, or 12 through 16 are going to be your, like your D3 resection. And a lot of those are like pericaval or periaortic or like base of mesentery, and so we don't really go after those.
I hope you heard all that. Meg.
I did. Thank you, Clem.
Resection margins should be at least 4 millimeters or 4 centimeters. That's why that one's wrong. And then prophylactic splenectomy has not been shown to improve outcome among similar stage patients. This is for patients who don't have any obvious disease in their splenic hilum, though. All right. Sure.
45-year-old male, history of alcohol use arrives in an ER. Hematemesis is tachycardic but non-intensive. He gets a liter, normalizes his heart rate. Placement of an NG tube produces bloody drainage, which rapidly clears with a warm signal wash. Appropriate management includes which the following: immediate EGD, immediate IV vasopressin followed by endoscopy in 24 hours, immediate upper GI contrast exam, observation in the ICU. And there's a role for vasopressin, but I don't know what the timeline.
Yeah, no. What they're getting at is that early endoscopy increases the likelihood of you finding the suspected lesion, and they quote early endoscopy is within 12 hours, not within 24.
These patients should get like antibiotics and other things. So that's kind of the difference between if it's variceal, they do get antibiotics and some of those other things.
Correct. But this is basically just getting at doing an urgent EGD to identify location of bleeding. When you get
60-year-old man has orthostatic symptoms when blood per anus during the initial evaluation. There antibiotics and inflammation and conjunctivitis. Most appropriate next step. So I think for this one they want you to do an NG tube for that source.
And you would be right. So history of diverticulosis, they say is non-contributory in this case because patients in this age group have a lot of diverticula. Maroon stool is suggesting that blood has been present in the GI tract for a long time. So, but that's not sufficient to pinpoint the location of the bleeding. So the best step is to put an NG down to try and determine whether or not it is proximal or distal to the ligament of Treitz.
You have questions on like how much bleeding in
No, I don't.
So CTA,
Yeah,
so CTA can go up to like 0.3 mils per minute. And then tagged red blood cell scan, I've seen it as low as 0.05 or as high as 0.1. I think the thing to know is that like tagged red blood cell, while it's supposedly like more sensitive for like you can pick up less bleeding, it's actually like less specific. And so it's not as good as CTA at pinpointing where the bleeding actually is. So that's I think the confusion.
Angiography is even more.
Yeah, actually angiography is 0.5 is what I see.
Yeah, so CTA is better.
Oh, yes. So 0.3 for CTA, 0.5 for angio. So start with CTA unless they're hemodynamically unstable, and then blood.
But that would be the question. Get CTA first or the straight? CTA first.
What are they talking about, Anne?
They're talking about CTA versus tag red blood cell scan and how much bleeding you need in order to identify, or in order for them to be like to successfully identify and pinpoint a location of a bleed. So for a tag red blood cell, what were you saying? You need less than it's like
0.05 mils per minute.
0.1 to 0.05 mils per minute, whereas CTA is 0.3 mils per minute.
Angio is 0.5. Just remember the angio is like the highest and tagged red blood cells the lowest.
So angio, you need more bleeding in order to identify it, and a tag red blood cell, you need like you can identify or pinpoint the location of a bleed with less bleeding per minute. Does that make sense?
Yeah.
A 60-year-old male opened to room 3 months after a distal gastrectomy with Bill Roth 1 reconstruction for bleeding peptic ulcer. His chief complaint is lightheadedness, weakness, and a racing heart 2 to 3 hours after a meal. What is most likely cause of his symptoms? So this sounds like late dumping syndrome. So it'd be hypoglycemia.
Right.
What's early dumping system? Early dumping syndrome, which of those answers?
Okay.
Right.
So they're not, that'd be like within like 30 minutes.
So we're talking about early versus late. Early 30 to 60 minutes, late 60 to 180 minutes. Early, it's a hyperosmotic load, causes fluid shift in the bowel. You get hypotension, diarrhea, dizziness. Late, you get hypoglycemia secondary to an increased insulin release. Treatment of this: small, low fat, low carb, high protein meals with no liquids, no lying down after meals, not creatide. So it's a lot of just behavioral, and you treat it by having them alter the way that they're eating.
A 55-year-old man with an upper GI bleed secondary to a bleeding duodenal ulcer continues to require several blood transfusions after 2 ETDs and attempted interventional radiology embolization. There's known after Ulcer Disease and taking PPIs. What is the most appropriate next step? A, repeat ETD, B, brain aftercare, C, a gastro artery ligation, D, galving, E, neutrectomy, and vagotomy. I want to say brain aftercare.
So does he have a separate
it-
ulcer or is he?
Yeah, is that gonna address bleeding as well? Maybe bleeding duodenal ulcer.
So kind of two separate pathologies to some extent. Both can be from ulcer disease, but you have a perforated ulcer, duodenal ulcer, and a bleeding duodenal ulcer. Yeah, so where are those two? Like they're both in the first portion of the duodenum, but where are they? Because they're presenting different.
It can be, but that's not very common.
Yeah, so if you have an anterior perforated duodenal ulcer, that's what we treat with a granite edge. Typically not a lot of bleeding in that position. If you have a posterior duodenal ulcer, that's what causes the massive bleeding.
And it's usually bleeding from the GDA. So Meg, what they were saying is that 2 pathologies with ulcer disease, you have perforation or bleeding. Perforation usually happens on the anterior wall of the duo, whereas bleeding posterior, and the bleeding is usually secondary to the GDA. Due to erosion from a posterior ulcer.
Yeah. So you do a stitch here.
Oh, it's okay. I have a picture of it.
Oh, nice. Oh, nice. Beautiful. Beautiful.
Here's the great plan.
I was an art major, if you guys didn't know.
This is a picture. You do an anterior duodenotomy, and then throw either like there's said you throw like a U stitch, or you throw a U stitch underneath the GDA, and then you do a top and bottom to encircle the GDA. Although when I showed this picture to Martin the last time I gave this lecture, he's like, "You can't see any of that. You're just
Yeah, you just throw stitches.
you're just stitching until it stops bleeding." So, sorry, Meg, I didn't show you the picture. This is the picture we're looking at.
Thank you.
You're welcome.
I remember it from your last lecture.
And the whoever Adam is. Sorry, Adam. We're not trying to ignore you. All right.
40-year-old woman, third time in 1 month of gastric pain, blood work is normal. CLP, blood ultrasound, GI, all very normal. Procedures next.
Right. So how would you diagnose that? Right. Epigastric pain in somebody who's had a Roux-en-Y it's commonly due to a marginal ulcer. It's a common sequelae of the gastric jejunostomy. You have vulnerability of the jejunal mucosa to the gastric juices. You have to do an upper endoscopy in order to diagnose it.
How are you guys?
Good.
These are the thank you notes that I was gonna have everybody fill out for Dr. Popper. Can I put them in your office, please? And then just get all the residents to take one, fill it out, and just collect them all by Thursday. I'll come pick them up midday.
Okay.
Otherwise, I'm going on vacation and I won't see you guys until the actual morning of Wednesday. We ordered the box lunch and all that. Okay, thank you.
Thank you, ma'am.
Where are the modeling receptors located? I think they're gonna be, I think it's D.
So the smooth muscle cells. This is just one of those rote memorization of your GI hormones. So motilin's a hormone released from the small intestine, plays a role in gastrointestinal motility. Majority of the receptors are located on smooth muscle cells of the GI tract. Erythromycin binds motilin receptors and is used to treat gastrointestinal motility disorders. Your parietal cells secrete the hydrochloric acid and intrinsic factor. They're located in the fundus in the body of the stomach, and then the enterochromaffin-like cells aid in gastric acid secretion via histamine release. All right, Meg, you got this one?
A 56-year-old woman presents with a 6-month history of vague epigastric pain, early satiety, and weight loss. EGD shows a 3-centimeter mass on the gastric cardia. A biopsy reveals adenocarcinoma, and EUS shows T3N1 disease. Further metastatic workup is negative. She has a good functional status, ECOG performance status 1. What is the most appropriate treatment of this patient? 3-centimeter mass. I guess I'm between C and E. I don't know if you would try to do neoadjuvant to like clean up the nodes first. I will go with E.
I like that answer. Dr. Vreeland likes that answer too. It
He
enhances,
loves neoadjuvant. That's why I did it.
yeah, enhances resectability. Early administration of systemic therapy means that more patients will complete neoadjuvant therapy prior to getting surgery. So for
this is the cross trial, right? I don't know if C were
so basically C clinical T2 or above or any N need multimodal therapy. But if they do have N positive, they're more likely to complete chemotherapy if they get neoadjuvant rather than adjuvant. This is just going through the different stages of gastric cancer and the associated EUS. I just pulled this from Vreeland's lecture, basically. So muscle is bright. No, muscle's dark, submucosa is bright. So the first dark layer is your mucosa. If it invades into that, it's a T1A. If it invades into the submucosa, it's a T1B. That's the first bright layer. T1B gets a formal resection with a lymph node dissection, whereas T1A, you can do an endoscopic mucosal resection. If it invades into the muscularis propria, that's that second dark band, it's T2. And then into the serosa or beyond the serosa is T3 and T4 respectively. And then the chemotherapy regimens, the ones in Vreeland's lecture, the MAGIC trial, 3 cycles of epirubicin, cisplatin 5-FU, that's ECF, pre-op and post-op. And then FLOT4 looked at ECF versus FLOT, which is 5-FU, leucovorin, oxaliplatin, and Taxol. Then they did 4 cycles pre-op and post-op. And the FLOT4 patients did better. But I did link Vreeland's lectures, or I just put the links in at the end of this PowerPoint if you want to like review them.
So summary, T1, T2, you can do upfront surgery. T3 or higher nodal disease, neoadjuvant, and then everybody gets preoperative imaging to rule out metastatic disease, and everybody gets a diagnostic laparoscopy to rule out metastatic disease as well. First new status should come up for testing. Yeah, I think MSI for all.
MSI. MSI, CDH1, and HER2 for
T1A technically can be treated in this T1B.
But like he was saying, you also need to do like the diagnostic laparoscopy to make sure that they don't have diffuse disease.
This diffuse type is more of the diffuse type.
And diffuse type is way worse than intestinal type.
Diffuse type. I think that's what it's.
Oh, sorry, Meg. I didn't show you the picture. Really? All right.
23-year-old one.
Well, we could ask one of the interns.
Eyeballs check, and we can just go ahead and perm cap in it. And follow-ups about
I mean,
official it isn't related, but go on, like, maybe just bang out a perm cap. Figure out what's going on in their head. I think a carotid duplex would have a little money maker for the program.
I put the legs on for Wednesday with Davies, Garcia, and Medellin. We'll take the Medellins back down tomorrow and see. And then I don't know. I mean, if you want to do sorry. HIPAA.
What's that? Todd?
Just because we don't have any bariatric.
It's got to be like, I know, that's the problem.
sleeves and 2 bypasses this week. It's gonna happen.
Especially when you're on overnight, this has got to be like a reflex thing for you. Okay, so post-op, if they've had a Roux-en-Y or a sleeve, any evidence of new onset tachycardia could suggest an enteric leak. And that's the thing we fear the most. So if people have new onset and sustained tachycardia, you really need to be letting your upper levels know if the nurses are calling you overnight on these post-op bariatric patients when you're checking on them and doing their post-op checks. Just one of those things that you cannot miss.
Is it not what I would think?
They're always nauseous.
What would you do?
So if somebody called you and they said this person had new onset tachycardia, and they'd had a sleeve, aside from doing labs, what imaging studies would you order in order to determine whether or not they had a leak? Exactly.
Well, it's 2 a.m. and that means that we have to call in the 4:0 tags and then we have to pay them overtime. So
You're here,
we're really not gonna do that.
So what's another option is what she's getting at.
Because that is exactly what's gonna happen if you order a statin.
Exactly. Which was what Graham will do. But he'll wait for 3 hours while they wake up.
I've done it. So, yeah.
What contrast would you start with? So the word I read is start with gastric, I think. And then if that's negative, then you do like
Don't give a very
It'll get all the way up there. All right, Graham, this one's you then.
Okay. 51-year-old female with stenosis, upper endoscopy reveals some mass rising from the proximal posterior gastric wall with normal overlying mucosa. CT confirms this is an isolated lesion. Emergency laparotomy.
I like it.
Gastrotomy and wedge resection.
I didn't write the question.
Tissue analysis shows a 4.5 centimeter mass with 1 to 2 mitoses per high powered field. Proximal tumor margin is less than 1 mil.
Which of the following is the most appropriate next step? Exploration, celiac dissection, proximal gastrectomy without lymph node dissection, adjuvant, external beam radiation, 1 year observation with serial CT scan. I'm assuming this is like a bleeding gist, maybe. I don't remember what the cutoff is for.
5.
No. Are you guys already anticipating what I was going to say for mitosis?
Yes, we were actually.
Okay. Okay. So you're saying it's low risk then? I'm just going to say not.
Actually, because it's low risk.
Oh, I thought there was very low risk, moderate, and high. No. Okay.
No, so low risk, less than 5 centimeters, less than 5 mitoses per high powered field, no rupture, no peritoneal mets. Therefore, they don't need gleeback. You've resected it, and your margins are negative, so they don't need any additional surgery. They don't get
certainly meets the size criteria, right? Which is less than 5.
right.
And you're saying that the mitosis is 5.
Less than 5,
Less than
yeah,
5.
to make it a low risk.
I think it's 36 months. At least that's what I have written down. I also have written down that that's for like non-resected. I'm pretty sure if you're doing active, 36 months. Exon 9 is the most common. Exon 11 responds less Is it good in that? Is it good in those? And that's but it doesn't go to those. Okay.
Now he's saying it doesn't go to those lymph nodes. Exon 9 and 11 have been implicated. If they have 9 is most common, 11 11 requires a doubling of the Gleevec dose because it doesn't respond as well to the Gleevec.
Is Clem reading from Tommy Brown's book?
No,
No, he's reading from the back of his eyelids.
no, he's just,
It's just that
It's-
good, Meg.
yeah, it's just, he's got it all. He's got it all in his head.
It's gonna be you this year, Meg. 99%. Meg Pratt. AAM. I've already started writing it up.
Yep.
All right.
Following conditions not considered to increase the risk of gastric cancer. I believe it's hypoplastic.
Yeah, I believe you are right. So adenomatous polyps are what increase your risk of gastric cancer, not hyperplastic ones. And then previous partial gastrectomy and pernicious anemia are also risk factors. So chronic gastritis, like chronic inflammation.
What did they say for previous partial gastrectomy? What did you say?
They said a 3-fold increased risk of gastric cancer also exists among patients who had previously undergone partial gastric resection. Post-gastrectomy cancer is a long-term concern. Increased incidence of malignancy is not observed until 15 years post-operatively. No, they don't mention them.
I think there's.
Oh no. Shh, Meg, you're not allowed to answer that one. All right. Yeah, I think so.
A 52-year-old man lived with Roux-en-Y gastric bypass removal with obesity. He had 100 centimeters of approximate bypass. He returns 1 year later with complete scattering, fatigue, and weakness. He has positive fecal fat study, macrocytic anemia, and micronutrient deficiencies. I think this is likely bacterial overgrowth. From the stem. I would say bacterial.
Yeah.
Positive fecal fat study, that's like, that's positive, that's what.
Yes. That's your like pathogen monitoring for it. But this is blind loop syndromes, just decreased motility, stasis in the afferent limb leads to bacterial overgrowth.
No, I think if you have a positive, so I think if you do have that, then you don't have fecal positive fat stuff. It can be okay. I think that, like, that's the only thing that I read.
Mhm.
I think it's like.
Now we're just to the rapid fires. 2 types of gastric volvulus.
Organoaxial and
Mesoaxial.
Sure, yeah.
So organoaxial along the axis, and then mesoaxial, you bisect both like the greater and lesser curve. If you're gonna do a truncal vagotomy, what do you need? Oh, sorry, Michael.
Probably. He's not currently using it for dialysis.
What?
If you take out the vagus, you should remove the gallbladder.
Right, but more simple than that.
I would have to look at the face.
Like a step back from that. If you're removing the antrum,
You can just, what's the?
or no, if you're doing a truncal vagotomy,
Yeah,
like
that's what I was gonna say.
what are you innervating?
Oh, so you also need to be a team procedure.
Right. Yeah.
I would do both.
Most common problem following a vagotomy?
Insufficient. Oh, well. If you actually do the vagotomy, yes. But if you don't, then recurrence is sufficient.
I don't know. This one says diarrhea.
Oh, okay.
Oh, so they're saying like you've done it.
Right, yeah. Top 3 risk factors for rebleeding at the time of EGD. Okay. All right. And
So this is the what classification?
this is the Forest classification. Sorry, I don't know what the diffuse using is. Yeah, we talked about that. All right.
Shorten the limb.
Or
Wrong.
the
I
bronze.
was like, no.
I just shortened the limb. I think it's super
That
fucking
one,
short.
that one was like specific for the Bill Ross.
I usually just. I
was like, specific for the Bill Roth too, okay?
He's like,
Leave it alone. So what's a brawn entera?
Really? It wouldn't be like an obstruction. But that's-
I know, that's kind of weird, right? But it's, yeah, it's gastric obstruction, not whatever. Yes, that causes a delayed emptying.
Okay, got it.
Most common complication?
Oh, I thought it said cause, most common cause of death.
See, we do need to go through the rapid fires.
Bleeding, anemia.
Perforation.
Perforation. Incest.
Perforation is
Wait,
the most common, really, complication of a gastric ulcer.
I didn't write
So
that.
chemotherapy typically for gastric cancer is usually like what I was going to say is usually includes platinum and 5FU.
Yeah, I don't know who wrote this one, so I would agree with you. But 5FU, epirubicin, and cisplatin are the ECF. Yeah. I've continued that tradition. This one, I didn't really like that, so I'm just going to give you that one.
Yes. Like,
This is like for you guys.
It's cystic with common.
Uh-huh.
Second, and third, first we do.
I always always get it wrong because it's the points of the triangle, not the sides of it. So like that, once I realized it's the points of the triangle, it makes sense. Like those locations.
That's why it's a rapid fire question. Sorry, Meg, you don't have those rapid fires. Most common mutation in diffuse gastric cancer, CDH1, gastrin level greater than 1,000 is Ollinger-Ellison syndrome, and your gastronoma triangle is the confluence of the cystic and common bile duct, junction of the second and third portion of the duo, and then junction of the head and neck of the pancreas. And then this is just to go over the Seaworth classification, tumors involving the G junction. Type 1, 5 centimeters above to 1 centimeter above the G junction. Type 2, 1 centimeter to 2 centimeters below. And then type 3 is 2 centimeters below to 5 centimeters below. And your management changes based on where those are. For the higher ones, your type 1s, you're going to treat them more like esophageal cancers. They're going to require an esophagectomy, even getting into the type 2. And then type 3, depending on your margins, you may be able to get away with a gastrectomy. Oh, and then the GI hormones. I mean, we can go through this, or you guys can go through it on your own, but basically this is just kind of like rapid fire through these. So it's produced, gastrin is produced by, you just didn't answer.
Just advance her. Meg, my new job is to advance you.
Oh, thank you.
I don't know what that means.
Produced by G cells in the antrum. Your secretion is stimulated by amino acids, parasympathetic, spelled wrong, or Vegas input. So your acetylcholine, calcium, ethanol, and pH greater than 3. So you're inhibited by too much acid, pH less than 3, somatostatin secrete CCK. Targets parietal cells and chief cells to secrete hydrochloric acid. So you get increased HCl, increased intrinsic factor, and then carcinogen secretion. Somatostatin produced by D cells in the antrum, and it's stimulated by acid in the duo. It has many targets. It's an inhibitor, so you don't want acid in your duo, so it's going to shut things down after that. You get inhibition of your gastrin and hydrochloric acid release, inhibition of insulin, glucagon, secretin, and motilin, and in general, it just decreases your pancreatic and biliary output. CCK is produced by I cells in the duo and jejunum. Secretion is stimulated by amino acids, fatty acid chains. You get gallbladder contraction, relaxation of your sphincter of OD, and then increased pancreatic enzyme secretion, so like exocrine pancreatic function. Secretin, S cells of the duo, stimulated by fat bile and acid, so low pH, inhibited by high pH and gastrin, and then your response is bicarb secretion from the pancreas. It typically inhibits gastrin release and inhibits HCl, however, it does not inhibit gastrin release in cases of gastrinoma. Vasoactive intestinal peptide, produced by cells in the gut and pancreas. You get stimulated by fat acetylcholine. You get increased intestinal secretion from it, so water and electrolytes. It improves motility. Glucagon, alpha cells of the pancreas, stimulated by parasympathetic acetylcholine, amino acids, low glucose, inhibited by high glucose, high insulin, and somatostatin. This causes gluconeolysis, gluconeogenesis, lipolysis, ketogenesis, secretion, and all the other things. Insulin, I hope you know where those come from. Obviously, secretion is stimulated by glucose or CCK, inhibited by somatostatin, and then you get increased cellular glucose uptake, promotes protein synthesis. Pancreatic polypeptide, islet cells in the pancreas, you get secretion stimulated by food, vagal stimulation, or other GI hormones, and then you get decreased pancreatic and gallbladder secretion. Motilin, we talked about intestinal cells of the gut, stimulated by food in your gut or jejunal acid, inhibited by somatostatin, which inhibits everything, secretin, pancreatic polypeptide, and duodenal fat. So basically, you get increased intestinal motility. And then I just added on Breland's lectures on gastric cancer for you guys to review on your own time. They're good things to review. They help with both the esophageal and the gastric cancer. And he goes over the endoscopic ultrasound really well too. And he goes over the.
You got all that, Meg?
Lot 4.
Yes, thank you for advancing me.
These are on the L drive, so when you guys go to review your GI hormones, I know it's just rote memorization.
Thank you so much, Dr. O'Shea.
You're very welcome, Dr. Flatley. It's good to talk to you.
Bye, everyone. Miss you.
Thanks.
Thanks, Ian.
Yeah, I don't think we need this.
Regarding breast, if patient has you have to do an orthodontist.
Yes.
Now here.